at the Association of State and Territorial Health Officials. The purpose of today's webinar is to highlight programs and policies that address the infectious disease consequences of opioids. I am honored to welcome you to this virtual session on behalf of the CDC. During the ASTHOConnects, a CDC representative will discuss evidence-based practices to reduce the harmful health outcomes associated with injection drug use. In addition, state and local representatives from Vermont will share their perspectives on policy levers and activities needed at the community level to implement syringe service programs. We hope that you will benefit from the panelists' expertise and perspectives. We apologize, we're having some technical difficulties, but we'll get that straightened out right away. Our goals for this webinar are to describe the infectious disease consequences of the opioid epidemic, share resources and evidence-based tools that help participants understand their state vulnerability to the infectious disease consequences of the opioid crisis, explain syringe service programs and how these programs benefit clients, communities, public health, and healthcare systems, and provide an example of how Vermont is using policies and partnerships to reduce the harmful consequences of opioid use. Our first presenter is Dr. Alice K. Asher, who will discuss the epidemiology of infectious consequences of the opioid epidemic. Alice Asher is an associate research fellow at the National Center for HIV, AIDS, Hepatitis, STD, and TB Prevention at the Centers for Disease Control and Prevention. Dr. Asher has worked with people who inject drugs around the care, treatment, and prevention of infectious disease for almost 20 years, including serving as a project director for a prospective cohort study examining hepatitis C in young people who inject drugs in San Francisco, running a clinical trial of a hepatitis C vaccine tested with people who inject drugs, and as a clinical nurse specialist at the San Francisco Needle Exchange. Her work at CDC focuses on addressing the rise of infectious diseases as a result of the opioid epidemic, providing technical assistance to local communities, improving linkage to care for persons who inject drugs, and conducting research to identify opportunities for evidence-based interventions. Alice?
Thanks for having me here today. Sorry, I'm trying to move forward. There we go. The disease increasing at the highest rate as a result of the opioid epidemic is hepatitis C, largely because persons who inject drugs are at disproportionate risk for transmission due to unsterile injections and the viremic nature of the virus. In the US, we estimate approximately 6.6 million people have ever injected drugs, and over 775,000 have injected in the past year. Hepatitis C incidence occurs at a rate of about 23 per 100 persons years. And in 2018, CDC estimated that there were 2.4 million Americans living with hepatitis C. In 2016, there were over 41,000 new hepatitis C infections, representing a 3.5-fold increase since 2010. Only 48% of the new infections provide risk information. However, almost 70% of those that do cite injection drug use. New hepatitis C infections are not the only issue. You can see from the blue line on the graph on the right that in 2012, for the first time ever, deaths from hepatitis C outpaced those of all other nationally notifiable infectious conditions combined. And in 2015, there were almost 20,000 deaths where hepatitis C infection was indicated as a primary cause of mortality. The rapid rise in new cases of hepatitis C are not the only issue. An additional concern is the changing face of who is getting hepatitis C and where new infections are rising fastest. Whereas traditionally hepatitis C infections were primarily occurring among men and in metropolitan areas, since 2010, infections are now occurring equally between males and females, and non-metropolitan areas have the fastest growing incidence of new infections. This is largely due to the dramatic rise in rates of injection drug use in recent years. On this graph, you can see that core areas with core-based statistical areas, or CBSAs, of more than 1 million people, shown here in blue, have had a relatively steady rate of injection drug use in their populations, whereas CBSAs of less than 1 million people, here in orange, have grown, and areas outside of CBSAs, here in gray, have seen a dramatic rise in injection drug use. We can see from this graph that the more rural an area is, the greater the increase in their injection drug use population. In the past few years, hepatitis A has become a major problem as well. During 2017, a total of over 1,500 outbreak-associated hepatitis A cases were reported from California, Kentucky, Michigan, and Utah, with 71% of them in hospitalizations and 3% resulting in deaths. Overall, over 50% of these patients reported drug use, experiencing homelessness, or both. And currently, more than 11 states report outbreak-related hepatitis A virus among persons who inject drugs. Hepatitis A and C aren't the only sequelae related to increasing opioid use. In areas hardest hit, hepatitis B infections are also increasing among persons who inject drugs. It's not just viral hepatitis. This bar chart shows the percentage of invasive methicillin-resistant Staphylococcus aureus, or MRSA, cases among persons who inject drugs by year at 6 surveillance sites between 2005 and 2016. In this analysis, invasive MRSA infections that occurred among persons who inject drugs were those frequently associated with non-sterile injection drug use. Demographic shifts in the population of invasive MRSA infections among injection drug use mirrors those observed in the ongoing opioid epidemic, such as the increased proportion of cases among whites, demonstrating similar patterns that are seen in the incidence of acute hepatitis C, as well as in the rate of drug overdose deaths involving heroin, with notable increases in both beginning around 2010. Syringe services programs are an essential community-based program that can help prevent infectious disease complication of injection drug use. However, their number and geographic spread limit their effectiveness. It was estimated that in 2018, there were 320 syringe services programs in operation. However, the average American has to travel more than 90 miles to reach one. Additionally, they must go over 17 miles to access medication-assisted treatment and more than 11 miles to access substance use treatment facility. The map on the right shows cases of hepatitis C among persons under 30 years old, identified using commercial laboratory data. The red dots are each a case of hepatitis C, the black locations of syringe services programs. This analysis found that only 20% of persons under 30 with hepatitis C live within 10 miles of an SSP. Over 2,000 additional syringe services programs are needed for proximal access. So what is a syringe service program? I think generally we expect them to be places where you can provide sterile injecting equipment and a means for disposal of used equipment, as well as accessing risk reduction education. But perhaps most importantly, syringe services programs represent opportunities to engage persons who inject drugs in care. Research shows that people who work with a healthcare provider at an SSP are more likely to connect with primary care. Syringe services programs can provide services in testing and screening for hepatitis C and HIV. They can offer patient navigation and case management to address comorbidities. They can provide naloxone distribution and education to prevent overdose. They can provide infection prevention education and wound care, vaccinations for hepatitis A and B, as well as access to mental health care and other social services. Syringe services programs do tend to encounter a fair amount of community concerns. It's important to know that SSPs do not enable high-risk drug use. They provide a means for safe disposal of used syringes. They do not increase community crime, and in fact, they contribute to the safety of first responders and law enforcement, as well as other community members. This data comes from CDC's National HIV Behavioral Surveillance System, which monitors HIV infection, risk behaviors, and HIV testing and use of prevention services in high-risk populations. This analysis calculated SSP coverage by determining annual number of syringes dispensed per person who injects drugs in 1 year and the estimated population size of persons who inject drugs in the region analyzed. They used binary log transformation for the SSP coverage variable, so the interpretation of the model prevalence ratios is for every twofold increase in SSP coverage. Looking at engagement in high-risk injection practices, they found that for every twofold increase in SSP coverage, participants were less likely to receptively share syringes. That is, they were less likely to use a syringe that someone else has already injected with, and they were less likely to do so with 2 or more people. There was no difference in sharing other injection equipment, such as cookers. They also found that for each twofold increase in SSP coverage at the city level, participants were more likely to safely dispose of their used syringe. There is no evidence that SSPs increased illegal drug use or crime. This study in Baltimore measured a number of arrests before and after the introduction of a syringe services programs and compared an area with the SSP to an area without. Overall, they found no change, no difference between the areas with an SSP and that without. And in fact, the area with an SSP saw a reduction in the number of break-ins and assaults after the establishment of the syringe services program. SSPs can help keep first responders and law enforcement safe. As many as 1 in every 3 officers may be stuck by a used needle in his or her career, and needle stick injuries are among the most concerning and stressful events experienced by law enforcement and have been ranked as equivalent to a knife or gunshot wound. By providing safe syringe disposal and reducing the community presence of syringes, SSPs help protect the public and first responders. Perhaps most importantly, SSPs serve as critical entry points to substance use treatment. Persons who inject drugs who use syringe services programs are 2.8 times more likely to reduce the amount they injected compared to those who don't use syringe services programs. New users of SSPs were 5 times more likely to end drug treatment than those who don't use the program. And persons who inject drugs who use SSPs were 3.5 times more likely to stop injecting compared to those who don't use SSPs. While I didn't touch on the recent clusters of HIV infection related to injection drug use, there have been several recent events, most notably the 2015 outbreak in Scott County, Indiana. There are more than 60 published studies that show the effectiveness of syringe services programs in reducing injection drug use related to HIV infection, resulting in a pooled estimate of 56% reduction in HIV infections. In fact, a modeling study showed that had an SSP been opened in Scott County by January 1st, 2013, HIV infections would have occurred in at most 56 people, compared with the actual number of over 200. SSPs also play an essential role in reducing hepatitis C transmission. Studies show that medication-assisted treatment alone reduces the risk of hepatitis C transmission by over 50%. When combined with good access to a syringe services program, the risk of hepatitis C transmission decreases by 74%. SSPs are also cost-effective. The lifetime estimated cost of treating 1 person living with HIV is almost $500,000, and the annual costs of treating hepatitis B and C have been estimated at $5.8 million and $1.8 billion, respectively. And hospitalizations in the U.S. due to substance use-related infections can cost over $700 million annually. By comparison, a comprehensive syringe services program can operate for just dollars per syringe distributed. Federal funds can be used to support SSPs. The Consolidated Appropriations Act of 2016 modified the restriction on the use of federal funds for programs distributing sterile needles or syringes. The provision still prohibits the use of federal funds to purchase syringes or needles for the purposes of injection, any illicit drugs. However, it does allow funds to be used for other aspects of SSPs based on evidence of a demonstrated need by the health department and in consultation with CDC. Jurisdictions do need to demonstrate that they are experiencing or at risk for increases in hepatitis infections or an HIV outbreak due to injection use. Federal funds can be used to support staff or personnel, including program staff and planning staff, monitoring and evaluation activities, supplies including alcohol pads, sterile waters, and cottons, testing kits, syringe disposal services, navigation services to ensure linkage to care, and medical care and mental health care, provision of naloxone to reverse drug overdoses, education materials, condoms, communication outreach activities, and also planning activities. Again, they can't be used for needles, sterile needles, and syringes or other devices used for illegal drug injection. However, it's important to know this usually is a very small portion of the expenses of running a program. Additionally, non-federal funds, including tribal, state, and private funds, may be used for the purchase of these supplies. So as mentioned, the first step is to apply to redirect for a determination of need, and then apply for permission to redirect funds to the appropriate federal agency. The good news is many areas already have a determination of need in place. As of December 10th of this year, 35 states and the District of Columbia, 1 tribal nation, 1 territory, 8 select counties, and 1 city all have determination of needs. There are currently 17 states and territories that have no request or determination of need pending. CDC does offer a few helpful resources to help people who are interested in beginning to plan for a syringe services program, and we're available for technical assistance if people need more information. Thank you so much. I'm going to withhold questions from the end. I apologize for going a bit over, but I'm really excited to hear from my colleagues in Vermont about the work that they're doing.
Great. Our second presenter is Daniel Daltry, who will discuss the Vermont state prevention efforts related to infectious consequences of opioid use and statewide syringe service programs. Daniel Daltry has over 20 years of experience in the field of STD and HIV care, education, prevention, and surveillance in both Philadelphia and Vermont. Daniel serves as the program chief of HIV, STD, and Hepatitis program at the Vermont Department of Health. There, he oversees state surveillance, prevention, and care efforts for HIV, STD, and hepatitis. Daniel is responsible for overseeing the state implementation of syringe service programs. He also volunteered in the field of syringe service programs at Prevention Point in Philadelphia. In addition, as part of Vermont's Sexual Disease Investigation Program, Daniel designed and implemented a virtual media program aimed to reduce STD risk among adolescents. Daniel holds a master's in social work with a focus on social administration from Temple University. He's a member of several advisory committees, including the chair of the Vermont HIV Community Advisory Group and the chair of the National Coalition of STD Directors Public Policy Committee. Daniel?
Thank you all. Thank you for having me today, and it is a true honor to be presenting here from the perspective of Vermont to the rest of the nation. Clearly, there are many excellent models across the nation. I am honored to be able to present the approach that we have taken here in Vermont. I'm a bit of the bridge that comes between our subject matter expert, Dr. Asher, and our field expert here in Vermont, Grace Keller. I'm excited to be sandwiched between 2 brilliant minds and also representatives of programs of excellence. So it's a great position to be able to present with such strong colleagues and also to the rest of the nation. Thank you for listening to what I have to offer today, and maybe I will be able to inspire some ideas if you haven't already thought of it. Who knows if you already have. Here in Vermont, as well as the rest of the nation, we're engaged in dire times. The rate of opioid death has now surpassed the peak of HIV deaths that we once saw when we were in the midst of an HIV pandemic. As of 2015, we have greater folks that are dying from opioids than we did HIV in the early days. This is a staggering problem. It's one that keeps evolving, and it's rapidly evolving, especially with the rapid progression of fentanyl and the inability to access pure heroin. Greater and greater heroin is diluted. What do we do in the midst of this war? What do we do in the midst of a nation that is struggling with opioids? Our commissioner recently published an article, a journal article, that talked about 6 compelling ways that we can begin to try to leverage resources and policy to try to address the opioid epidemic. The 6-pronged approach focuses on leadership, partnership and collaboration, epidemiology and surveillance capacity, education and prevention, treatment and recovery, harm reduction, and overdose prevention efforts. So today, in the midst of our presentation, given the time that we have, and also wanting to keep you all awake and not bore you, I'm going to focus just on 3-pronged approaches that we have taken here in Vermont that might be relevant to you. So I would like to talk, first of all, about the issues here in Vermont and what we are facing related to opioids. Like most of the nation, access to pure heroin is getting increasingly hard. With that has come some challenges, especially the rate of overdose that happens when fentanyl is introduced into heroin. Part of the key components is not only increasing syringe service programming, but increasing the ability for folks to be able to test the supply that they have before they inject, such as making fentanyl strip tests available. Now more to the story about what is happening here in Vermont and the importance of partnership. The work that we are doing at the Department of Health could not happen without partnership. Partnership from the feds and the ability to use funds for comprehensive programming related to syringe service programming. Even if we are not allowed to spend funds currently on syringes or needles, there still are ways in which we can leverage access or funds that are available from the feds into our programming. Today, I'm going to highlight some of that. We need to have internal partnership. Again, this work could not happen without partnership. It can't just be an HIV, STD, and hepatitis C leading the way, maybe leading, but it needs to be done in tandem with other stakeholders, both within the state government and in the community. Internally here at the Vermont Department of Health, we have worked intensively with our Alcohol, Drug, and Assistance Program, Environmental Health, Department of Corrections, and our Governor's Council and Attorney General. Again, engaging these stakeholders has been critical in terms of the legality of these operations, but also leveraging entry points for consumers to have access to syringe servicing programs. Additionally, pardon the typo, I should have self-corrected, but external partners are critical. This work could not be done without syringe service programs that are happening in the field. We need to engage law enforcement. So before a program opens up, we make sure that our syringe service program has at least engaged community businesses as well as law enforcement about the operation they intend to do. We have had great support throughout the state of Vermont from legal officials, law enforcement, in helping to address the battle of opioids. Waste management, believe it or not, they are stakeholders in this as well, especially with products that have been used and how to manage and dispose of. We have created pilot disposal programs for different counties in order what to do if they find used syringes in the community. It's a rarity, but it still happens, and a community, I think, feels all that more safe when they know there's a resource available. The second important thing here is to know your epidemiology and what is happening related to infection. As Dr. Asher mentioned earlier, there was a vulnerability study that was done. For some reason, my thing is not moving. Sorry, okay, I'm back. So again, Vermont was identified in terms of the vulnerability study. We are currently working on updating the vulnerability study to look further at the impacts in Vermont that are happening. But as you see, 2 of our 14 counties have been identified in terms of where an outbreak might happen next. Fortunately, as we continue to look at HIV here in Vermont, we continue to see a high proportion of our HIV cases, both new and prevalent cases, being among men who have sex with men or gay identified men. Fortunately, IDU continues, or people who inject drugs, continues to be a lower proportion of our new infections. Could that be because of our wide distribution of services? I think we're accessing the tip of the iceberg in terms of population, but certainly between primary and secondary exchangers, we are reaching a significant number of individuals. And hopefully that's part of the reason why we see such a low impact of HIV currently among people who inject drugs. We know some of the common statistics. Dr. Asher already reviewed this with you. You maybe have already researched this on your own. What I want to highlight here in particular is that in Vermont, 1 in 15 folks that are newly diagnosed with HIV are people who inject drugs. Another statistic that I think is important, at least from a Vermont perspective, when we look at our estimate of individuals living with hepatitis C, there's anywhere from 20 to 30,000 folks that are living with hepatitis C, as well as managing opiate dependence. That's a significant proportion. Currently, through our syringe service programming, as you'll see, this has been an evolution and we've ramped up. We currently have access to greater than 5,000 people who inject drugs. But still, as you can see from the slide before, it's a small portion of the folks that we estimate are using or managing opiate dependency throughout the state. More statistics. Sorry, it's not advancing. Okay. So again, through the years, we've continued to see hepatitis C on the rise here in all counties, not just one. We continue to see, since 2010, we essentially have doubled in the number of cases that have been reported. We continue to see, though, the same cohort of age of significant concern, individuals 20 to 29 and 30 to 39. Next and final prong that I want to focus on is harm reduction and overdose prevention efforts. This is where the work is done. This is the genius of operation that's needed to try to address the impact of opiates among consumers and prevent death, save lives. As we know, syringe exchanges often have an impact in an individual's life. People can't do this alone. People that have been using for a number of years need a peer, need a mentor, need somebody that is going to reach out to them and show them the way as they begin to make strides towards sobriety, if that is a choice of theirs, or how to manage their use. That's the genius of a syringe service programming. Yesterday, we heard a warm testimony at our community advisory group meeting where one of the individuals talked about the brilliance of a syringe service program to him is that while he was engaged in treatment, he kept getting banned from different treatment facilities. And it didn't matter that of the 9 drugs that he was currently using, even though he made progress and stopped using 8 of the 9, because he was using 1 of the 9, he got kicked out of that program. With syringe service programming, we have a warm body, a friendly soul that's engaging an individual that's in the midst of use and working with them on their continuum of care as they strive for recovery in their own terms to whatever degree that is. And in doing that, we are saving lives. In Vermont, the history of syringe exchange isn't as long maybe as some of the other areas identified, but doesn't mean that it's any less meaningful. You know, I've heard about how quickly Kentucky has adapted in terms of becoming, I think, the 2nd largest provider of syringe service programming in the country, and that was in the course of 1 year. Things can happen rapidly if you align or allocate your resources to your need. Kentucky is certainly an example of that, In Vermont, we have a little bit of a longer history. Our first syringe exchange started in 1998. In 2013, thanks in part to the efforts of Grace Keller, who you're about to hear from, a Narcan distribution pilot project was able to begin. Now, you don't say syringe service programming in Vermont without knowing that Narcan is a part of the backbone. Thanks to Grace, we have saved lives because of the Narcan operations that are happening throughout the state, and that was a part of a statute that was introduced and accepted by our legislation. There are new things on the horizon. There are new opportunities, particularly as we look at comprehensive syringe service programming. Who knows what is ahead? What I know right now and what we offer through syringe service programming, such as Safe Recovery, which you are about to hear about, we have Suboxone that is offered, we have buprenorphine treatment, we have fentanyl testing, we have disposal opportunities for the folks that are in the midst of addiction. What is next? Who is going to be the first in the nation to open a safe injection site or an overdose prevention site? We're on the zenith of we're on the precipice of great change, and we continue to evolve to serve the individuals that are ever so struggling with this issue. In Vermont, the efforts began again in 99, with a legislation that was introduced and accepted to permit syringe service programming throughout the state. We have an annual application process where individuals are able to apply and receive a letter from our commissioner if the application is complete, and they can justify how they will be able to serve individuals through the use of syringe service programming in tandem with their community and community leaders. Syringe service programming, as Dr. Asher mentioned, the gold standard certainly has a number of components to it, all of which you will hear from Grace Keller in about 3 minutes. In Vermont, I really feel fortunate to be here in Vermont. We hopefully will have, if we are doing this presentation in 1 year, I would be saying to you that all 14 of our counties have some reach or service for syringe service programming. Right now, just in the lower quadrant, southwest quadrant of the state is the only area in Bennington County that we currently do not have a syringe service program operation. There is strong community interest. Hopefully within the next 6 months, that will be in place and all 14 counties will have some level of syringe service programming, be it through fixed site or mobile exchange. We also, as we continue to fund syringe service program through a combination of state and federal funds, we engage our grantees in terms of developing meaningful measures that help to not just justify the work, but also highlight the excellence that is achieved. These are measures that are easily agreed upon by our syringe service programming because it's part of what they do. As I've mentioned earlier, our syringe service programming has increased in terms of membership, as you see, but it's also radically increased in terms of distribution. At this point, we distribute more needles out and in than we have population as well as cows. That's an impressive feat in Vermont. There are many cows. The cost of that distribution, this life-saving effort, is really, if we look at the public health brilliance versus the fiscal cost, it's pennies. It's literally pennies for the amount of impact that we are having in terms of saving lives, preventing further treatment, as Dr. Asher illustrated earlier, and bringing individuals into care and living lives. I want to thank you for your time, and I want you to encourage you to strap on your seatbelts and get ready for Grace Keller and the amazing work that she is doing here in the state of Vermont. Thank you for your time today, folks.
Our final presenter is Grace Keller, who will discuss local implementation of a comprehensive syringe service program in Vermont. Grace Keller is the program coordinator for Howard Center's Safe Recovery Program, Vermont's oldest and largest syringe exchange. In that capacity, she has had extensive hands-on experience providing case management, support to clients who struggle with opioid dependence. In addition, she frequently provides testimony for the Vermont State Legislature on bills related to substance use, recovery, and treatment, such as the 911 Good Samaritan Act and the naloxone bill. In 2013, she was instrumental in implementing Vermont's first community-based naloxone program through Safe Recovery. The program provides naloxone to clients, their families, and community providers. Grace has a Bachelor of Arts from Trinity College in Hartford, Connecticut.
Hi, everybody. Thank you so much for having me today. I feel very fortunate to work with Daniel and Alice on this presentation, and they have really great statistics, so I'm going to focus more on programming. I feel like they've got a really good, you guys have a really good idea of what the statistics are showing right now, and I'm just going to show intervention more than that, and we'll have time for questions in the end. As Daniel talked about, we have an amazing partnership with our Department of Health. Vermont is a small state, which is great because Daniel and I actually run into each other on the street quite often, and we have very close communication, and that really, I think, helps to get all of these efforts up and running and continue to run. And when we have hiccups, we're in really close touch. So I always have to tell everybody how grateful we are for that. Safe Recovery is Vermont's oldest and largest syringe exchange. It's also the oldest and largest pilot site for Narcan. And we call Narcan a pilot site because that's how that passed the legislature, but we believe that program will continue in perpetuity. It's just sort of a technical thing. So
Hi, Grace. I think we lost your sound. Hi, Grace. If you can hear us, we lost your sound.
Hi, everyone. We're trying to get in touch with Grace.
Yes.
It seems like she maybe can't hear us.
She was on a phone line, and it looks like her phone line has gone. So I stopped the share, so hopefully she will get notice.
Okay. Great. We appreciate everyone's patience while we work through this. Thanks so much.
I just sent Grace some text. Hopefully she'll get those.
Great. Thank you.
Yep.
Do we want to take a question or two while we're waiting?
That's a great idea.
Yeah, so I think we received a question during Alice's presentation that was directed towards her, so maybe we can go ahead with one of those. The question was, are there any joint projects with the USDA to promote this in rural areas? Assistant Secretary Haslett at USDA has opioid use intervention as a high priority. Any thoughts on that, Alice?
Yeah, so I'm aware of the USDA's interest in opioid use, and that there are even, I believe, some small business loans for people who are want to, for example, use technology to do things like telemedicine or teleecho projects for medication-assisted treatment or hepatitis C treatment. As far
I'm
as
back, if everybody, sorry about that. I don't know what happened. I'm back here. Sorry about that. I didn't realize. I was talking about syringes found in the community and our retrieval, and we gave out about 700,000, and we found 85 in the community. So we track them, we make sure that we know where they are, and for community support, we go and retrieve them anytime there's a syringe found in the community. Looks like I've lost control here. I'm having trouble with the control too.
If you just tell me, I'll advance the slide for you.
Okay, so who we serve a very high-risk population at Safe Recovery. 82% of our clients have experienced homelessness, 57% have been incarcerated, and 52 started using their primary drug by the time they were age 18. And we can advance that now. And in Vermont, we pioneered what's called a hub and spoke model for medication-assisted treatment. The hub is the methadone clinic or Suboxone clinic, and that's where we do a risk assessment, and our highest risk clients get referred to the hub, and then spokes are primary care doctors. So we have a centralized hub and then spokes where people can go. If they become stabilized, they can go to a primary care doctor. If they become destabilized, they can go back to the hub. You can advance that one. And Safe Recovery has worked very hard on overdose prevention efforts. We have handed out over 20,000 doses of Narcan. We hand out about 1,000 fentanyl testing strips a month. And we are working very closely with clients on risk reduction and risk reduction education. Despite those efforts, we still lost over 100 Vermonters to opioid overdose last year. And actually, we've lost more clients in the last 18 months than we have in the entire 18 years Safe Recovery has been in operation. Mm-hmm. So we're really focused on getting overdose prevention efforts to clients. And so with all of those efforts and trying to prevent overdose, we realized quickly that we needed to do something else. So we'll advance the slide. And like I said, we gave out Narcan, which is the overdose prevention, overdose reversal medication. If you give that to somebody who is overdosing, they will begin, it will reverse the overdose, and the person will be able to start breathing again in very short order. We give this to clients, their family members, their friends, and anybody who might be present in an overdose. So we've trained over 1,000 providers in the community on Narcan. And as a result, we've had over 1,360 people come back and say that they've used it. We know that number is underreported because those are all people that came back and sat down with us and did a form. So as you imagine, there's probably plenty of people that didn't have the time or weren't interested in doing the form with us. And we can move that one along. Fentanyl testing strips are strips that test for the presence of fentanyl in any drug that somebody might be using. We had a very recent tragedy in the city of Burlington where 2 people thought they were buying cocaine. They were opiate naive, and they both died together in their apartment. And unfortunately, their roommate came home later and found them both deceased. They had no idea that there was fentanyl in their cocaine. We're finding it in a lot of different drug supplies. So we're really focused on giving people fentanyl testing strips to make sure that they are able to test any drugs that they are taking, that they are aware of the presence of fentanyl if it is there. And what surprised me is we have had people report that they have thrown drugs out where they have found fentanyl. We also, a lot of people report that they mitigate their drug use, they use less, or they make sure that somebody else is with them and has Narcan if they are going to use the fentanyl. And on intake, we ask everybody if they've ever witnessed an overdose. And traditionally, for the entire 17 years prior to this year, it's around 26% that have witnessed an overdose. And in one short year, that number jumped up to 81%. 57% of clients have overdosed themselves. So in Vermont now, we have sufficient fear around fentanyl, and people are really trying to take care of themselves and other people that are using. You can move the slide along. And like I said, we have distributed just close to 700,000 syringes out of Safe Recovery, and we've retrieved about 300,000 have come back to us. What we're really focused on is making sure that people dispose of syringes safely and effectively. Safe Recovery has clients from every county in the state of Vermont, and around 34% of our clients come from Chittenden County, outside of our county. So a lot of people can't get back here to return their syringes at a regular rate. So we worked with the Solid Waste District and the Department of Health to create safe disposal at home. So we've trained people that they can put their syringes in a laundry bottle, a hard plastic bottle, and place them in their garbage, not recycling, to make sure that they're disposed of safely and effectively. So we train people to get dispose of their syringes as quickly as possible and as safely as possible. We can advance next. So our newest efforts, because we have been losing so many clients, is we are doing a low barrier buprenorphine program at Safe Recovery. And we started that about 5 weeks ago. We got a grant from SAMHSA, and we're working with our state health insurer. And what we are doing is we're offering buprenorphine to anybody who is in the syringe exchange. And we're getting to the highest risk people because we're really meeting people where they are. The beauty of the hub and spoke system in Vermont is that it really works to coordinate care and get people into the appropriate level of care. The one drawback it has is that for the highest risk people, if they burn a bridge at the hub, then treatment in Vermont no longer applies to them, because if you cannot get into the hub, you're not going to be able to get into any of the spokes. So we wrote a SAMHSA grant to be able to keep that population here at Safe Recovery. We're going to be able to give them dosing wheels, which are wheels where they have medication, the medication in on a daily basis. It opens up for a short period of time, like an hour or two. People can get their dose for that day, and it seals back up. And they are tamper-proof. Somebody could tamper with them, but it would be as extreme as running them over with a car, and it would be very clear that they did that. So for that population, we're able to keep them here. What's very exciting for us is that that population has always been our clients. We've always cared for those people, and we've watched what's happened to people when they don't have access to treatment. In Vermont, we had a very long waiting list. For the majority of my career, and I've been here 11 years, we had a 2-year waiting list and for medication-assisted treatment, and the person would have to call in every month. And so a lot of people didn't get treatment, and as you can imagine, people with the most chaotic lives, or people who were homeless, or people who struggled with mental health issues, they really couldn't get through that system. So now we are offering it in-house. We have a doctor, our first doctor that we hired, and I say first because she had 30 spots, and we filled those spots up in 8 days. The other piece of it is we are trying to get people fed into the hub and spoke system. So the ones that are able to move on, we're moving on, and we have a social worker and case managers wrapping services around those folks. And you can advance that slide. And so what's happening here now is, and what I've always known, is that a lot of people in the syringe exchange would rather be in treatment, but we just have to meet them where they are and treat them with dignity and respect and care for them in a setting that's comfortable. And for the low barrier buprenorphine program, what makes it low barrier is that they don't necessarily need an appointment. They can walk in. And that really works for this population. They aren't penalized for polysubstance use, so if they use other drugs or if they relapse, they have the same prescription and they have the same, and they aren't kicked off their medication. And we accept a lot of other behaviors that other programs don't. So we really work hard to make sure that we know that we are life-saving, and we know that people access to medication and access to Narcan is really what's keeping people alive. So we have never no trespassed a client from here. We've never kicked anybody out of our program, and we think that's absolutely essential. So Safe Recovery has 5,137 members. We've given out over 20,000 doses of Narcan, and 100% of our clients reported that they were treated with respect and provided necessary support. So we really feel like that was one of our most important statistics. You can advance it. And we have 1,328 overdose reversals reported. Next one. So that's most of it. Sorry for the technical difficulties. That kind of threw me for a loop, but I'm here for any of your questions. One of the things that we are really proud of is that we have great partnerships with law enforcement in Vermont, and that's not that common in syringe exchange. So the other day, the police arrested a mid-level drug dealer, and he was very emotional and stressed out. So they literally dropped him off at our door and told them if he engaged in treatment that they would drop all of the charges. So we were able to get him into treatment within the next 45 minutes. And he has been adhering to treatment ever since. We don't share that information with law enforcement, but it's very promising that they are our biggest supporters. The law enforcement and the Department of Health are our biggest supporters in Vermont. So we really feel like all of these interventions are reducing people's risk for HIV and reducing people's risk for hepatitis C and overdose. So thank you very much. If you have any questions, feel free to ask.
Great, thank you so much, Grace, for that wonderful presentation, and thank you so much to all of our presenters today. We have a few minutes to do some questions. Participants, please feel free to chat into the chat box any questions that you have while I ask a few that we've seen so far. Alice, I think you may have been in the midst of responding to the question about partnerships with USDA while we were sorting out some of our technical issues.
Yeah.
Do you want to respond to that question? Thanks so much.
Yeah, quickly, just I'm not aware of any. I am aware of their initiatives, but that doesn't mean that CDC isn't. We're a very large agency, and I just work at one center. I can try to follow up and pass that information on to ASTHO for you, though.
That would be wonderful. Thank you so much. Moving on to a couple of questions that we received during Grace's presentation. We got a question from Gerald, which said that buprenorphine is great. Do you have any issues with patients diverting the medication, for example, patients selling it? Grace, is that something that you've seen in your work?
So we've only been doing this for about 5 weeks, and we do have, we are testing all of our clients. We have diversion protocols in place, diversion prevention protocols in place. So we're testing all of our clients. Clients are given UAs every time they come in. And what we found also with the UAs, if clients know that they're not going to lose their prescription for using other substances, the UAs have become much more therapeutic. So we have clients that report, I used heroin this week, and in the UA, it actually comes up as fentanyl. So we can talk to them as you thought you were using heroin, but you actually were using fentanyl. So in all of our patients, buprenorphine has showed up in their urine. We're doing very small, short prescriptions for people. So usually they're coming in at least twice a week. And when we have the dosing wheels up and running, because we just got the SAMHSA grant, we'll be using the dosing wheels and doing random callbacks also. So we really aren't seeing that. What we have seen is we're treating people who no one else would treat, some people who are struggling with alcohol, people who are struggling with a lot of other drug use, and we're seeing significant reductions in other drug use, in polysubstance use, and alcohol use in their UAs. So we're able to see that other drug use is coming down. So it's really more promising than anything negative. We have not really witnessed any of that yet.
Great, thanks so much, Grace. And you actually answered the next question in as part of what you just shared. We did get one more question around whether you've seen any precipitated withdrawal with the low barrier buprenorphine.
So we haven't either. We're working on, we're using, and low barrier buprenorphine is being done in other parts of the country. So luckily we've had a lot of consulting with other programs. And we're working on there is a model that's for home induction. And so we haven't seen that, and no clients have reported that, and we're asking about it. So clients are doing home induction. We do have a subset of people that were already using buprenorphine on the street, and we call that street induction. So a lot of people have used these medications illicitly and know how to prevent that, but we haven't, we have had 40 patients, we've moved 10 out, and we currently have 30, and we haven't seen that. very often. The other great thing I quickly want to say in Vermont is that we passed a law where all inmates are offered and provided medication-assisted treatment if they were coming into the jail, prescribed it or not, and transitioning out of the jail, they're coordinating care. And I think we're going to see large reductions in overdose deaths with that initiative, low barrier buprenorphine alone. For the illicit buprenorphine question, our police department and our state's attorney have recognized that buprenorphine is much safer than any of the other drugs that are on our streets right now. So as part of the initiative, we have low barrier at the hospital, low barrier at safe recovery, and they have announced that they're not going to arrest or prosecute for anybody who's caught with buprenorphine. So we have a really comprehensive way of looking at encouraging safety for people and getting people to a safer place. I think fentanyl has just brought everybody to the table in a different way and had people look at this and think of different solutions, because we just have had so many people die here in Vermont from overdose.
Thanks so much, Grace. And I wanted to just touch base on one other question that we got around whether ASTHO would be able to provide any guidance or information on how states may be able to make treatment of HCV for state residents more successful, given some issues around payers and things like that. We're very happy to check in with our counterparts on the infectious disease team, as well as the Center for Population Health, and potentially put something together and share that with you all. So be on the lookout for that. And I'll turn it over to Ioana to wrap us up.
Thank you again for joining us today, and I apologize for the technical difficulties we've had. We'll make sure that future programs don't have similar issues. I would like to thank the CDC for supporting this webinar, and if you could please fill out a brief 1-minute evaluation at the conclusion of today's webinar. It should be on the last slide of this PowerPoint deck. The evaluation will provide us with useful information for our future programs, and please also be on the lookout for a link to the recording and PowerPoint deck. Thank you, and enjoy the rest of your day.